Today's presentation will include a PowerPoint presentation, and then we'll have a few minutes for questions and answers at the end. Before we begin, I would like to take a moment and invite you to visit our webinar page at www.pocus.org, where you can find all previously recorded webinars, searchable by topic. Our presenter today is Dr. Koratala. Dr. Koratala is an academic nephrologist and currently the Director of Clinical Imaging for Nephrology at the Medical College of Wisconsin in Milwaukee. He is a nationally acclaimed leader in POCUS, well known for his educational tool, nephropocus.com, and the recipient of the 2020 American Society of Nephrology's Innovations in Kidney Education Award. He has designed and developed a longitudinal POCUS curriculum for nephrology fellows, which continues to serve as a model for institutions incorporating this skill into nephrology training. In addition, Dr. Koratala works closely with the American Society of Diagnostic and Interventional Nephrology and is involved in developing certification standards for POCUS in nephrology. He also serves as the associate editor of Ultrasound for the Renal Fellow Network. It's our pleasure to have you with us today. Take it away, Dr. Koratala.
Hey, thanks for the kind introduction, Tori. Okay, here you go. I hope everybody is able to hear me well. So thanks for having me here today. And we'll be talking about the venous congestion, which has been receiving a lot of attention lately. And this is just a brief overview or introductory lecture to venous congestion and not really an exhaustive presentation today. I do not have any conflicts of interest. So in terms of assessing a patient's hemodynamics, when we are dealing with patients with altered hemodynamics, whether it's critically ill patients in the ICU or those with cardiorenal syndrome, we've been paying more attention to the forward flow component. That is the heart pumping fine, and how is the mean arterial pressure, and are we able to improve the cardiac output by giving more fluids, that is fluid responsiveness. But the venous component, on the other hand, that is the backward flow, has received little attention over the years. So, when we look at the organ perfusion pressure, it's actually the difference between inflow and outflow. Because organ perfusion pressure is what we want to maintain in a hypotensive patient, right? So, and when we look at this inflow pressure and outflow pressure is usually the mean arterial pressure for the sake of simplicity. And the outflow pressure is the central venous pressure or intra-abdominal pressure when it's elevated. So the difference is what determines how well the organ is being perfused. So we take care of the inflow pressure frequently, but forget about outflow pressure. What if the CVP is very high? So that's when organs take a hit. That's when they develop congestive injury, congestive liver failure, congestive kidney injury, and so on. And there is a lot of data that suggests that elevated central venous pressure, or in other words, elevated right atrial pressure, leads to increased kidney afterload, and which eventually leads to kidney congestion, thereby leading to acute kidney injury. That's called congestive kidney injury. And there are several causes for elevated CVP. It could be heart failure, post-cardiac surgery, mechanical ventilation, and iatrogenic fluid overload when we give fluids to patients in shock without really paying attention to their actual hemodynamics, or raised intra-abdominal pressure, pericardial and pleural effusions, pulmonary hypertension. All these things can raise the CVP and contribute to acute kidney injury. And it's not just the kidneys that take a hit, but almost every organ in the body will suffer from fluid overload. For example, in the lungs, fluid overload causes impaired gas exchange and increased work of breathing. Heart, it leads to conduction abnormalities, impaired contractility, impaired relaxation, and both short-term and long-term effects. In terms of central nervous system, the patients can develop impaired cognition and delirium from fluid overload. And in the liver, it leads to impaired synthetic function and cholestasis. In the gut, malabsorption and ileus. And in the skin, it leads to poor wound healing and eventually pressure ulcers, which contribute to increased risk of infection and the vicious cycle of sepsis. So how do we assess the backward pressure? So inferior vena cava ultrasound is probably the simplest way um, to estimate right atrial pressure, right? So essentially it's a tube that's connected to the right atrium. It more or less reflects the pressure in the chamber. But we know that isolated IVC ultrasound has several pitfalls. For example, it's not really uncommon to confuse IVC with the aorta. We know how to combat this pitfall. For example, we try to pay attention to where the IVC is going. We want to make sure it's going to the right atrium. We also want to make sure the hepatic vein is joining the IVC, and aorta tends to have anterior branches while IVC doesn't have. We know all these things, but still in clinical practice, either because of suboptimal image acquisition or patient-related factors, this can still happen to anyone. Similarly, when we want to measure the exact collapsibility index of the IVC, that is when we are trying to see like by how much the IVC is collapsing, whether we use M mode or not, the point that we are looking at might not be the same when the patient takes a deep breath versus before the patient takes the breath. So for example, you can see the M mode cursor here. Initially, we placed it at the place normally we would want to measure, that is just below the inferior vena cava hepatic vein junction. And when the patient takes a deep breath, that point is changing and the line is almost coming to the inferior vena cava right atrial junction. And what's there at the inferior vena cava right atrial junction is the diaphragm, and there is always some pull exerted by the diaphragm. So when you are not measuring the same point here, look at this M mode trace on the right side. When we are not measuring the same point, the final measurement, that is, if we are saying the inferior vena cava has decreased from 3.89 centimeters to 1.75 centimeters here, that's inaccurate, because this 1.75 centimeters has actually come from this point and not the initial point. So, and also, apart from this, we also know that patients' respiratory effort varies depending on the situation, and not all the patients have same degree of effort, especially when they are not stable in the outpatient setting, like we see in the echocardiography lab. And sometimes you can confuse other structures with IVC, such as you can confuse caudate lobe of the liver with IVC because they're like pretty adjacent to each other. And as you see in this example, this is actually a duodenum with echogenic bowel contents that can be confused with IVC. And the clue that it is duodenum is that apart from these echogenic contents, you can see the feeding tube here. And yeah, I mean, like anything else, these things happen very frequently in clinical practice. Also, like the angle of insonation can change while we are acquiring the image of the IVC, and we may feel that IVC is collapsing while in reality it's not really collapsing. Here you can see this image nicely demonstrates the diaphragmatic pull here at the junction of the right atrium and the IVC. That shouldn't be considered as collapse. That's one thing. The second thing is we have to be looking at this area here. That area in reality is not collapsing, but when the operator's hand is moving, it appears that there is a collapse here because the ultrasound beam is not passing through the IVC, but it's actually passing through the liver. So there are several limitations. We can make the whole presentation about IVC limitations. So what is VEXUS then? I mean, especially if you're active on social media, you're probably hearing a lot about this. VEXUS is essentially venous excess ultrasound grading system. So in addition to inferior vena cava ultrasound, it involves hepatic vein Doppler, portal vein Doppler, and intra-renal venous Doppler to see how the blood is flowing, to assess the venous waveforms, and assess the overall congestion. Or in other words, this method allows us to look at the major abdominal veins and how the blood is flowing inside them. So here is the landmark paper recently published on this topic. And this is by a great Canadian group of critical care physicians and nephrologists. So what they found was, this was actually a post hoc analysis of a paper in cardiac surgery patients that showed that portal vein pulsatility and intrarenal vein pulsatility in post-cardiac surgery patients was associated with worse outcome. So in the same cohort, they did post hoc analysis and found that when the IVC diameter is more than 2 centimeters, or more than or equal to 2 centimeters, if you see severe flow abnormalities or severe Doppler flow abnormalities in at least 2 of the veins out of those hepatic, portal, and intrarenal, the risk of subsequent development of AKI was significantly higher with a hazard ratio of 3.69. So that's what they found. And also you can say, why not just IVC? That also reflects the congestion. So they also looked at the combined VEXUS score, which includes all these Doppler patterns and IVC, and also just looked at the central venous pressure that was measured in those patients. And they found that the post-test probability when there is a positive test was significantly higher when they used the combined VEXUS grading as opposed to CVP alone. So the VEXUS grading has outperformed CVP, or the substitute we use for CVP in clinical practice is IVC. So you can say that isolated IVC has been outperformed by VEXUS scoring. And to understand the VEXUS scoring better, to understand what we mean by severe flow abnormalities in 2 of the major veins, we need to know how the normal pattern looks like and what happens to these Doppler waveforms with increasing right atrial pressure. So first we'll talk about hepatic vein Doppler, and then portal vein, and then intrarenal vein, and come back to the VEXUS scoring. So first hepatic vein Doppler. And the lateral or the mid-axillary plane is the easiest plane to find a straight segment of the hepatic vein. And we want a straight segment because we get the best Doppler flow or the best Doppler tracings when the vessel or the flow is parallel to the beam, to the ultrasound beam. So if you are able to get a straight segment of the hepatic vein like this, which is in parallel with the ultrasound beam, it gives us the best Doppler shift. So then you find the vein and you turn on your pulsed wave Doppler mode and bring the sample volume or the Doppler gate onto this vessel, and you get the tracing. And also, like from the same lateral aspect, if we manipulate the probe by rotating it a little bit, most of the time we'll be able to see both hepatic vein and portal vein together in the same image. So hepatic vein, in normal circumstances, it's blue. Blue means the blood is flowing away from the transducer. So the transducer is here, and the blood in the hepatic vein flows away from the transducer and towards the heart or towards the inferior vena cava. That's why it's blue. And on the other hand, portal vein carries blood from the GI organs and goes into the liver. So it's coming into the liver, or the flow is towards the transducer here. So that's red. So towards the transducer is red, and away from the transducer is blue. And in general, hepatic vein is mostly blue and portal vein is red. And you can also acquire image from the subxiphoid view, where you normally look for the transverse view of the IVC and where these hepatic veins are joining. But because like all the 3 hepatic veins are joining the IVC here, sometimes the sample volume will catch more than one hepatic vein, especially when the patient takes a breath, and you tend to see some disturbed flow. So I personally prefer lateral aspect to acquire the images, unless it's not possible due to patient factors. So here is how normal hepatic vein waveform looks like. So it has multiple individual waveforms, very similar to that of the central venous pressure waveform. So we'll go over these individual waves. So like I said before, in general, red color is towards the probe and blue color means away from the probe. And when it comes to spectral Doppler or the pulsed wave Doppler, you have a baseline, and below the baseline is like blue color. That means blood is flowing away from the probe. And above the baseline is like red color. That means blood is flowing towards the probe. And as we said, the hepatic vein is blue. That means most of the tracing or most of the graph should be below the baseline. That's normal. That's the first point to understand. And let's see the waveforms. The first wave is the S wave. S wave is the systolic wave. That means it occurs during the ventricular systole. So look at the apical four-chamber view here. What happens during systole or the ventricle is contracting? So when you look at the right ventricle, here is the tricuspid annulus, and that moves towards the apex. When there is longitudinal motion of this right ventricle and it's moving towards the apex, it's making more room in the right atrium. So there is more place in the right atrium for the blood to flow in or for the venous return to go into that. So that's S wave or the first wave in the hepatic vein waveform. And then after the ventricular systole or towards the end of the ventricular systole, the tricuspid annulus starts to come back to where it was. So, and then that increases the pressure in the right atrium. So when you have increased pressure, the waveform goes towards the baseline and forms another small waveform, which is V wave. So V wave occurs at the end of ventricular systole. And now the next phase is ventricular diastole. So what happens during diastole? The tricuspid valve opens and the blood flows from right atrium to right ventricle. So that again makes more room in the right atrium or less pressure in the right atrium to allow the venous return. So more blood flows into the right atrium during diastole. So this is the D wave. In general, S wave is of higher amplitude compared to D wave. S is more than D. That means more blood goes into the right atrium during ventricular systole than ventricular diastole. And finally, the A wave. A wave is a positive wave. That means it is above the baseline. And it occurs during atrial contraction. So at the end of ventricular diastole, atrial systole occurs, right? So when atrial systole occurs, there is increased right atrial pressure. So there is backflow or increased pressure in the venous system. That's reflected as above the baseline wave, that is the A wave. So we saw S wave, V wave, D wave, and A wave. And they occur in that particular order. A, here is A, S, V is in the middle, and this is the D. A, S, V, D. That's how it occurs. And it always helps to have simultaneous EKG tracing when you're performing hepatic vein Doppler. So the reason is the P wave corresponds to the A wave, and S wave occurs just after the QRS complex, and D wave corresponds to the diastole on the EKG. And you can see that the hepatic vein waveform is pretty similar to that of CVP waveform. And EKG particularly helps when the V wave is above the baseline. So remember that V wave that occurs during end of the systole because of increasing right atrial pressure, that can be below the baseline like this, which makes it easy. Now you know that this is S wave and this is D wave. But sometimes the V wave, the V wave can go above the baseline. Then you will have like two positive above the baseline waves and two negative below the baseline waves. So without EKG, it's very difficult to know which is A wave, which is V wave out of those two positive or above the baseline waves. And similarly, it is difficult to know which is S wave and which is D wave among those below the baseline waves. Here in this tracing, you can see that here you have like several positive waves and several negative waves. You don't know if this is V wave or this is A wave, or this is V wave and this is A wave if you do not have simultaneous EKG tracing. And also one important thing to know is that there is always a respiratory variation, that during inspiration we have increased venous return. So the amplitude of the S and D waves increases during inspiration and reduces during expiration. So seeing like higher amplitude waves intermittently is pretty common. And there are several variations. I mean, the patient can have atrial fibrillation, where you would see irregularly placed waves, or sometimes in tachycardia, the S and D waves can fuse. So as we do more and more scans, we see more abnormalities and get used to interpreting them correctly. But having a simultaneous EKG trace really helps. And with increasing right atrial pressure, here is how the hepatic vein waveform changes. So you can imagine this scenario if you imagine the patient is having a tricuspid regurgitation, or the regurgitant jet is coming back during systole. So say if the jet is coming back or into the right atrium during the systole, that means there is increased right atrial pressure. So the volume of the blood going into the atrium during systole will get less. So that means the amplitude of the S wave will decrease compared to that of D wave. Remember, we said normally S is more than D. But as the pressure increases, the S wave becomes smaller and smaller. And ultimately, the S wave goes above the baseline, and you might actually see like 3 humps above the baseline, A, S, and V. And as the right atrial pressure increases further, you can see that all these above the baseline waves fuse, and you just have like one above the baseline, one below the baseline, one above the baseline, and one below the baseline pattern. And that's suggestive of severely elevated right atrial pressure. I mean, most of the times volume overload is associated with some degree of tricuspid regurgitation, but you do not necessarily need to have severe tricuspid regurgitation to see this pattern. So actually this last pattern was obtained from one of the patients who had actually mild tricuspid regurgitation, but a lot of fluid overload. And now coming to the portal vein. So portal vein, so hepatic vein is a tributary of the inferior vena cava. It's a pipe directly going and joining the hepatic vein. On the other hand, portal vein has sinusoids in between. If you take a look at the histology of the liver, you have the portal vein here, and you have the central veins that go to hepatic vein. In between, there are sinusoids. And sinusoids, for the sake of simplicity, you can imagine them as shock absorbers that do not let the exact amount of CVP transfer to portal vein. So you do not typically see all those waves that you see in the hepatic vein in the portal. So instead, you would just see more or less a continuous pattern with some dips in between. So these dips correspond to A wave of the hepatic vein. And remember, like for hepatic vein, most of the flow is below the baseline because it's blue, and portal vein is red. So most of its flow should be above the baseline. And if you see below the baseline flow for portal vein, that indicates flow reversal. And like I said, sinusoids do not allow the like one-to-one transmission of CVP. So there is always some percentage of the CVP that is transmitted to sinusoids, and some degree is shielded away from portal vein. And with increasing right atrial pressure, the pulsatility increases in the portal vein. So here you see relatively continuous pattern. And in normal circumstances, we say the pulsatility of the portal vein is less than 30%. So if you look at these like peaks and depressions, if you measure one peak and one depression or the dip in the same cardiac cycle, that should be less than 30%, 30. And as the RAP increases, the pulsatility increases. Here, the pulsatility is definitely more than 30%. Here, the pulsatility is about 80%, like approaching almost 100%. So when you take this highest point here and lowest point here, and look at by what percentage it's dipping. Or in other words, if you really want the formula, it's always like the ejection fraction formula, big number minus small number divided by big number. So you take this velocity here and this minus this velocity divided by the bigger velocity again. And here, as the RAP increases further, you can see there is to and fro pattern. That means there is flow reversal during systole. So this is diastole, this is systole, this is diastole, this is systole. So it becomes to and fro, almost similar to that of hepatic vein. It's just that the systolic reversal is above the baseline when it comes to hepatic vein and below the baseline in the context of portal vein. But one thing we need to know is that we usually evaluate portal vein only when the IVC is bigger. That means when you suspect venous congestion, because otherwise healthy and thin individuals, especially those who are young, can have pulsatile portal vein without elevated right atrial pressure. So that's one pitfall to be aware of. And similarly, patients with liver cirrhosis can have pulsatile portal vein at baseline, and you have to take the whole picture, evaluation of all the veins and evaluation of the forward flow and everything before you consider this to be significant or consider this to be indicating elevated right atrial pressure in patients with cirrhosis. For example, here is a portal vein tracing obtained from a patient with cirrhosis on the right side here. So you can see it's pulsatile. And this patient actually did not have any other stigmata of elevated right atrial pressure. And the same patient, hepatic vein, you can see like most of the flow is below the baseline. That means it's good venous return. And at the same time, you can also note that the waveforms seem to be less defined. And that's also commonly seen in cirrhosis because of the fibrosis. The pulsatility in the hepatic vein seems to be dampened. And there are some instances where the pulsatility in the portal vein can be dampened too. For example, there can be a cirrhotic patient with elevated right atrial pressure, but you do not see pulsatile portal vein because of periportal fibrosis or other factors. So anything can happen in cirrhotics. So we have to be cautious in interpreting these waveforms. And finally, the intra-renal Doppler. So intra-renal Doppler, we call it intra-renal because we are trying to find the veins that are inside the kidney. And why not veins outside the kidney? Because you want to know exactly how the renal parenchyma is feeling the pressure. The real renal parenchyma is somewhere here. So this somewhere like this cortex and medulla is the renal parenchyma. And interestingly, kidney is a closed system. It's encapsulated. It's within the capsule. So when the venous pressure increases and when there is leakage from these veins and there is interstitial edema, there is increased pressure within the kidney parenchyma, and that together with pressure from the capsule will create a tamponade-like physiology. You can call it renal tamponade. So that's why measuring the intrarenal vessels will reflect how the renal parenchyma is feeling the pressure. So we typically measure at the interlobular vein, which is usually which actually passes adjacent to the renal pyramid and turns into the cortex and becomes the arcuate vein here. So in between the adjacent pyramids, you will find these interlobar veins. Sometimes it might be very difficult to find those veins, and you can then still measure at the segmental veins, which are slightly bigger. But typically, you shouldn't be measuring veins outside the kidney because they can be pulsatile at baseline and may not accurately reflect what you're looking for. So to get a good intrarenal venous tracing, first you need to get a good grayscale image of the kidney and then try to get a good color image of the kidney. It's not always possible to get pretty color Doppler images of the kidney, especially in critically ill patients. And sometimes putting on the power Doppler might help because power Doppler will be able to identify low flows. And once you get some kind of idea where the vessel is, then turn on your pulsed wave Doppler and put the sample gate at the vessel of interest. As you can see, the renal vessels are very small. So most of the time, you'll get both artery and vein in the same tracing. That's actually a good thing. That's because, so arterial tracing, you get above the baseline because the arterial flow is towards the transducer and the venous flow is away from the transducer. And the venous waveform is below the baseline. So arterial waveform has these mountains and valleys. So the mountain is the systolic phase and the valley is the diastolic phase. So here is the systole and here is the diastole. Now venous flow is more or less continuous. It's just like portal flow. It's just below the baseline because this venous flow is away from the transducer. And having a simultaneous arterial waveform helps us to know the phases of the venous waveform, in what cardiac cycle it's becoming pulsatile, when it becomes pulsatile. We'll see that in the next slide. So these are all normal intrarenal waveform tracing. So here, this is a little bit wavy here, like the portal vein that we saw before. And this is a little more wavy, but not really pulsatile because there is good continuous flow in both systole and diastole. The waviness just appears at the end of the diastole that corresponds to a wave of the hepatic vein. And if you really carefully observe, you can see this little bit of positive deflection here in between these cardiac cycles that actually corresponds to a wave. So all these patterns are normal. But as the right atrial pressure starts to increase, you have increased pulsatility in the renal vein. So you'll start to see there is some discontinuous flow between systole and diastole. And eventually the systolic and diastolic waves separate. I mean, obviously we know this is systolic and this is diastolic even without EKG because we have the simultaneous arterial tracing on the top. So this is the systolic peak. So this venous wave must be systolic or the S wave. And here is the diastolic phase of the arterial. So this wave or this venous wave must be the D wave or the diastolic wave. So as the RAP increases further, the pulsatility becomes two distinct S and D waves, like we see in the hepatic vein. And eventually, as the RAP increases further, the S wave disappears and goes above the baseline. And above the baseline, we cannot see because of the arterial tracing. So you'll be seeing only the D wave or flow only during diastole. Like in the rest of the patterns, we saw that systolic wave reverses in hepatic vein, reverses in portal vein, and also in the reverses in the renal vein. So essentially what it means is with the increasing right atrial pressure, there will be D only flow. That means diastolic only venous return in all these waveforms. So now let's take a little closer look at the S and D. So here, this third image, you are seeing distinct S and D waves, right? Here you have this above the baseline arterial tracing. So you're not seeing what's happening above the baseline. So actually, if you take a closer look at it, and if you manage not to get the arterial tracing and just get the venous tracing, you'll actually see like A and V waves, and which is pretty much similar to that of hepatic vein waveform. So you see the S wave. Actually, you can see the faint arterial tracing here. So this corresponds to systole, and here is the D wave, corresponds to diastole. And in between S and D, you have the V wave, like you see in the hepatic vein, and you have here A wave. So that's a nice example showing anatomy of the biphasic or S and D intrarenal waveform pattern. And here is the monophasic or the severe renal vein congestive pattern where you see only diastolic wave. And if you do not have a simultaneous arterial tracing, if you have a real EKG tracing simultaneously, you can easily tell that this wave is not at the QRS complex. So it is in the diastolic phase of the EKG. So you definitely know that this is the D wave, even if you don't have the simultaneous arterial tracing. That's why when performing VEXUS scans, it's always advisable to have EKG tracing. So just to run through all of them in one slide. So this is a patient with CHF exacerbation and severe venous congestion. Here is a hepatic vein shows, like here is a all reversal. This is the fused wave of systolic, that is S wave, A wave, V wave, everything fuses to form one above the baseline wave. And this below the baseline wave is the D wave. So S wave, D wave, S wave, D wave, S wave, D wave. That's hepatic. And portal vein, there is no systolic flow here. It is 100% pulsatile. So here is the flow in diastole, no flow in systole, flow in diastole, no flow in diastole, systole. And intra-renal vein, there is only flow only during diastole here. That means it's severe congestion. And now coming back to the VEXUS score, how do we combine all these things? So for the purpose of scoring, they classified these waves into normal, mildly abnormal, and severely abnormal. So for the purpose of hepatic vein, normal is S more than D, and mildly abnormal is S less than D. That means as the RAP starts to increase, S becomes smaller and smaller, right? And eventually S reverses, and that's severely abnormal. In the portal vein, less than 30% is normal, 30 to 49% is abnormal, and 50% or more pulsatility is considered severely abnormal. And in the intrarenal pattern, the continuous flow pattern is normal, and discontinuous or biphasic, when you see distinct S and D waves, that's considered mildly abnormal. And severely abnormal is when you see only D wave, or when there is, that means when there is S wave reversal. So coming to the grading, so if the IVC is less than 2 centimeters, then usually there is real no need to perform VEXUS scoring. And grade 1 is when the IVC is more than or equal to 2 centimeters. Plus, maybe you might be seeing some mildly abnormal patterns, or even normal Doppler patterns, but the IVC is more than or equal to 2 centimeters. And when the IVC is more than or equal to 2 centimeters, plus you see at least one severely abnormal pattern, that becomes grade 2 congestion or moderate congestion. And when the IVC is more than or equal to 2 centimeters, plus there are 2 or more severely abnormal patterns, that becomes grade 3 or severe congestion. That means if the IVC is say 2.1 centimeters, and you see the portal vein pulsatility is 70%, and in the hepatic vein you see S wave reversal, you don't even need to do the renal vein, because renal vein is relatively difficult if you want to quickly get it by the bedside on most occasions. So if you have like severe pattern in both hepatic vein and portal vein, you probably don't even need to get renal vein. And VEXUS not only helps to diagnose congestion or acts as a stop point to fluid administration, but also helps you to monitor the progress with therapy. So here is a patient, dialysis patient. At presentation, the patient was severely congested. You can see the portal vein, it's 100% pulsatile with systolic flow reversal, little bit reversal here. And with continued ultrafiltration and during dialysis, so after you remove 6 liters of fluid over 2 sessions, the systolic flow reversal has disappeared, and most of the tracing is above the baseline, and even the pulsatility has improved. And after 13 liters of ultrafiltration, the portal vein has pretty much become normal. And similarly, hepatic vein, at presentation, it was showing only D wave below the baseline. That means systolic flow reversal. And after 13 liters of ultrafiltration, both S and D waves appeared below the baseline. So that's how we can monitor response to decongestive therapy. Similarly, here is a patient with CHF. And at presentation, the patient had like systolic flow reversal with like very bad to and fro pattern. Like this reversal is more prominent to the previous patient. If you see here, there is reversal, but it's only like a little bit of reversal. Here, like there is one big diastolic wave and big systolic reversal. And gradually with diuretic therapy, the pulsatility has improved, and like the whole the waveform came above the baseline here. And eventually in 5 days, with a good amount of urine output, the portal vein has become completely normal. This is how you can use in day-to-day practice. It's not just experience of some case reports, but there was this study where it's a relatively small study, but there are more studies that are emerging. 30 patients in ICU admitted with cardiorenal syndrome, and they found that in 87% of the patients with resolving acute kidney injury, they showed improvement in VEXUS grade. That's a very significant percentage, and tells you that you can use it to monitor progress. So we are pretty much at the end of the presentation. So like I said, this is just a brief overview and doesn't go into all the nuances involved. And as we do more and more scans, we learn more and how these waveforms behave in different scenarios. And just a word of caution, like with IVC ultrasound, or like with any other ultrasound while assessing hemodynamics, you never interpret even VEXUS in isolation. You always need to evaluate the pump, that means how the heart is working, the pipes, that is inferior vena cava and all the other Doppler waveforms, and the leaks, which means look at the pulmonary congestion, there is pleural effusion, look at the ascites and all those things. So pump, pipes, and leaks have to be evaluated in detail for complete hemodynamic assessment. So thank you so much. And if you are Twitter savvy, follow me on Twitter at handle nephropy, and you can also visit my website nephropocus.com for several basic POCUS scenarios. Thank you.
Thank you. Thank you, Dr. Koratala. That was a great presentation. Thank you for that information. For the attendees, if you have questions for Dr. Koratala, please use the question answer box and we will get your question answered here. We've got a few minutes that we can take some questions. So the first one that came in, how often do you find that the VEXUS significantly differs from the traditional POCUS exam, such as IVC exam, B-line, etc.? In other words, how often do you find you change the management based on VEXUS?
So in my practice, I'm a nephrologist. I'm not an intensivist, though I see ICU patients. So I feel VEXUS really helpful to guide the therapy. So sometimes, especially hospitalized patients who are admitted for heart failure exacerbation, their symptoms tend to improve very fast because their activity level is much lower than what they would be doing at home. And there is so much data showing that there is always residual congestion at the time of hospital discharge that brings back these patients and increases the rate of hospitalization. So VEXUS is very helpful to identify hemodynamic congestion and see if our diuretic therapy is effective or not, how these waveforms are changing. And also in general, like I said, with several pitfalls of IVC, I always try to see, to assess how severe it is, right? I mean, IVC first gets dilated with increased back pressure, then it reaches its compliance, and then the pressure gets transmitted retrogradely into all these blood vessels, and these waveform changes happen. So at first glance, it gives us a better idea of how severe the congestion is, and it also allows monitoring the progress. And yeah, I pretty much use it in day-to-day practice. It's useful.
Very good, very good. Okay, next question that came in. You said the V wave is because of return of RV back towards base of heart at the end of systole, ?
Correct. Yeah, V wave is in between S and D waves. That means in between systole and diastole. That means it occurs somewhere between the ventricular contraction and full-fledged ventricular dilatation, where the tricuspid valve opens and the blood flows from RA to RV. So in between, the tricuspid annulus moves back towards its original place. That's where towards the end systole is where actually the V wave occurs.
Okay, fantastic. Next question that has come in. Do you see splenic vein PWD for VEXUS scan?
Yes, I mean, VEXUS by definition does not include splenic vein at this time because these guys who did the study did not include splenic vein. But yes, it's like in general, we also look at splenic vein. Say, for example, for whatever reason, we are not able to find a reliable portal vein, or we are not able to get other venous waveforms, we do look at splenic vein in our practice, and it's thought to reflect what portal vein would normally show.
Great questions, audience. Keep them coming. Okay, here's the next one. Within young patients, is the pulsatility transmission of hepatic artery or just intrinsic to the patient's physiology somehow?
So we don't know exactly why the portal vein is more pulsatile. It is thought that in thin individuals, it's easy for the portal vein to show transmitted pulsations from the surrounding arteries. That's what is the most logical explanation that we think of. Yeah, but in general, like if the IVC is not big and we are not suspecting any hemodynamic alterations, it's better not to draw any conclusions from pulsatile portal vein in normal people.
Okay. Next question. Could a patient who is hypotensive and possibility of obstructive shock, would you also be seeing VEXUS waveform changes, for example, pulmonary embolism?
Ideally, yes, we should be able to see. Yep. I mean, it's not really validated in all the patients. So the study was mainly in the cardiac surgery patients. But logically, whenever there is increased right atrial pressure, you should be able to see these waveforms. That means when the IVC is big, if the particular condition is causing the IVC to be big, you should be able to see this. I mean, it's very common that even in constrictive pericarditis, it's not really an obstructive shock, but in constrictive pericarditis, you'll still see the diastolic wave reverses in the hepatic vein, and that's a well-known phenomena. So similarly, in any condition that increases RAP, you should be able to see these changes. It's not just well validated in studies yet.
Mm-hmm. Mm-hmm. Very good. Another question that came in, how do things change when patients are on the vent?
So mechanical ventilation itself, because it's a positive pressure ventilation, may increase the pulsatility to some extent. But as of we know from whatever data exists as of now, it doesn't appear to be significant that you should eliminate positive pressure ventilation as one of the criteria. I mean, so in that index study, majority of the patients were intubated. They did find that, like, if you just look at those particular subset of people who were mechanically ventilated, the likelihood of having, or the odds of having pulsatile portal vein was higher in those people. But I really don't know if those patients remained intubated after cardiac surgery because they were sick. That's why the portal vein pulsatility was high, or it was inherent to mechanical ventilation. That I am not sure. But only thing we can say is it probably has some effect, but that does not preclude its significance of utility in mechanically ventilated patients.
Okay, fantastic. Well, audience, I'll tell you, we've had so many great questions come in. We do try to keep our webinars to 45 minutes. So I know there's a lot of questions we have not gotten to. If you have a question that you would like to have an answer to, I encourage you to email us at POCUS@intelios.org. And we'll be able to answer some additional questions through email. I'll correspond with Dr. Koratala. We'll get some answers to those. I have also seen some questions come in about how to get certified through the POCUS Certification Academy. I will just redirect you back to our website, POCUS.org, and across the top menu bar, you'll find a certification tab that you can click on. And it will give you a step-by-step procedure on how you can do that and what the requirements are. And then, of course, if you have any general questions for the POCUS Certification Academy, that POCUS@intelios.org email address is the best way to get a hold of us. So with that, Dr. Koratala, I want to say thank you to you. We really appreciate you being here today. Great presentation, great information. Thank you.
Yep, thank you so much.
Thank you. And that, folks, wraps up our session for today. A recording of this webinar will be made available on the POCUS.org website. For more POCUS talks, check out our Focus on POCUS podcasts, POCUS blog posts, and of course, follow us on social media where we post regular POCUS clinical challenges. Thank you for attending our webinar today, and we look forward to seeing you on a future webinar. Thank you.